Good morning, good afternoon, good evening. Section 9. Here's our last weekend wrap up or block for wrap up. I hope this finds you all doing well. What a great opportunity it has been to work with you guys as we wind out our 8 weeks together. Just want to say thank you for everyone who's put in such good effort and who have made it such an enjoyable time to interact with you all. I've really enjoyed myself, and I know James has felt the same way. We had an opportunity, James and I, to connect at EIM in Salt Lake City last weekend. As a side note, it's a great conference, and if you ever get an opportunity to go to it, I highly recommend it. I consider it professionally rejuvenating, just to be around people who are so passionate about our profession, driving not only the literature and the science, but also asking the tough questions professionally. It's just a great conference, and it was a real pleasure to meet James and to interact with him, and just to again put a name to a face and to kind of exchange thoughts and ideas. So again, if you ever get a chance, highly recommend it. But it's been a pleasure working with you all, and I really want to say thank you for your efforts. So on that note, let's get move on to the wrap up. So from a housekeeping standpoint, make sure all your course assignments for Block 4 are completed. But everybody has responded to their posts that I have seen, and some really good dialogue. We went down a lot of different roads. And in this particular block, which was good because in previous blocks, we'd stayed pretty much to topic, which is fine. I have no problem with that because the topics are good, but I sometimes like to deviate, and some of us deviated down the roads of blood flow restriction training. And if you are not familiar with that, certainly check out, I believe it's Block A. Yes, I think it's Block A where we delved into that. If you're not familiar with that, I am certified in blood flow restriction training. I use it. I don't use it a ton. But man, on the right patient, it is a home run. Certainly on most post-ops, I use it, but failed post-ops, I definitely use it. Or anybody thinking about surgery, I use it. Any kind of pre-training, I use it. We talked about some dry needling. I also dry needle. I've been doing that for about 4 years. I'm not as energetic about dry needling. I think there's right times and places to use it. And we'll talk about that later in the wrap up. But so we got into some different stuff, which was good. Make sure you take the course survey. Please take the course survey because it really does help us. These courses have changed a lot. I've been doing this since 2012 in helping EIM, and it has evolved. They are, you may not believe this, but they actually are less work than they were for the student and for the instructor. They have changed kind of the methodology and the flow of the courses because we take your feedback very seriously. Make sure to copy and paste any articles you want from the Dropbox for future reference if you're looking to keep any of these articles, which I think is really important because in my mind, this is how we go to others, whether it's the public or other professionals. This is what we stand on. We stand on the literature. When I go to people, when I go to physicians, and they may want to do one thing, and I'm like, okay, well, let's just take a look at the literature. When I sit on committees, we argue based on what the literature says. So I would argue that you need to have these references because you're gonna want them because you're gonna be like, oh yeah, I remember in that class we talked about why aren't we doing orthotics? What was that reason, or what is the reason that we are doing orthotics, or why do we want to load into pain, or why is it we don't want to stretch much, or we do want to stretch? Like, all of those things are great places. Now, you certainly have been taught the skills to go look for articles, but I think you should probably download those, in my opinion, and keep them. Man, I have so many articles. My hard drive is just full. Moving on. No, oh wait, did I cover everything? Nope, yep, I covered everything. Okay, good. So, the Achilles tendinopathy stuff, load the tendon. I cannot be emphatic enough about this. Tendinopathy needs load. I've cited the police article versus ICE, or rather RICE, and police standing for progressive optimal loading, ice compression elevation. You get 24 to 48 hours to rest. And then you need to get off your butt and start loading it. Now that loading it can be just easy isometrics, but you got to start doing something because otherwise you just get weaker and weaker. And this idea that we need to sit around and wait for it to get better by resting, as I've stated in previous wrap-ups, is total BS. And we need to move on from that. And we need to be educating our patients. I just had a patient the other day who was terrified of, I've seen her off and on for probably 8 years. Gosh, maybe even more than that. Maybe it's been 10 years just because as I think about when my children were born and my kids 14 and 12 and yeah. Anyways, long time. And this time she came in for one visit because she's like, I fell, my knee started bothering me, but I could hear in the back of your head, you gotta get going. And she started doing some really easy stuff, like some straight leg raises. And then she started to do some step ups. And then she's like, I feel almost silly being here because my pain in the last 3 days has gotten so much better. She gets it. She finally gets it. We need to get it as a profession. Stop treating these people like China dolls and start treating them like the people that they are and the connective tissue that needs to be loaded, okay? Not about stretching. So you can stretch. There's some benefit in stretching. It's probably just more of a pain reliever than anything else. It's really not. If you think about what it takes to change connective tissue length, probably has nothing to do with changing length and probably has really something to do with a decreasing nociceptive input. Ankle ligamentous CPG interventions that are recommended. So for some of you, ankle sprains, manual therapy, that was a new concept. It seems somewhat aggressive, but again, why do we manipulate? Why do we provide mobilizations? We manipulate or we provide mobilizations to decrease pain. Some people were of the opinion that a thrust might be too aggressive. And so this is what I would say. When I thrust an ankle, an acute ankle, what I do is we'll just say talocrural because that seems to be kind of the most obvious one. I'll pull them into distraction and I'll say, does this hurt? If it hurts, I don't do it. I don't keep going. And I'll say, okay, I'm just going to do this. And I'll pull, I'll distract, and I'll let it go, and I'll distract, and I'll let it go a couple of times until they're relaxed and comfortable and they know what's happening. And then I'll get them to distraction. I'll put them a little bit on it, and I put it on that end range. And then I'll say, I'm going to give it a little thrust. And I'll thrust just a little bit. Then I'll build it, and I'll thrust it a little bit again, and then a little bit more, and a little bit more. So they just gradually, it's all in our approach to how we get people to relax and feel comfortable and decrease the threat level when we're engaging our manual therapy techniques. I use a lot of soft tissue mobilization along the ankle, along ATF, when they have pain. And I'll tell them, this is going to sting a little bit. And they'll be like, oh, okay. And I'll say, do you feel this? I can feel it. I'll feel it kind of tension up into my hand. I'll be like, that's going to sting. Oh, yeah, it does. How do you know that? Can you feel that? And, obviously I tell them what I feel under my hands as being this stiffness within the connective tissue. But if you prepare them, if they understand what's going on, if we communicate with them, manual therapy to an acute injury should not be a threat, and it should be pain relieving. Heel pain, CPG, stretching, manual therapy, foot orthosis, night splinting, taping, all have some validation. I would argue that there's also needs to be some strengthening put in there, intrinsic strengthening. I quoted a couple of articles with loading the intrinsics. Irene Davis from Harvard, who is a physical therapist, does a lot of research on running. She's done some really good research on intrinsic strengthening. We know about the history of, or perhaps you're familiar with, the barefoot running craze and how that came out of, now I'm drawing a blank on the book. Anyways, all this barefoot running and strengthening the intrinsics. Different groups, different Aboriginal tribes, native tribes have been running in bare feet for the longest time. This idea of we needing to control pronation with shoes is kind of absurd, and we really should be just getting stronger. Certainly orthoses have been shown to be effective in the short term, but after 6 months most people don't wear them or need them. All of these things provide a short-term bridge to getting out of pain. Okay, patient case. Role of the SIN. So most people got this, right? And what's really important about the SIN stuff is that we understand that this helps us in our clinical decision making. And the biggest one, in my opinion, is irritability. You need to know how irritable this patient is because that determines how aggressive. If you assume they're highly irritable and they're not, and you're not pushing them hard enough, ain't going to happen. They're going to be like, well, this is dumb. This is too easy. I can do this. If they're super irritable and you start loading them heavy and they can't handle it, they're going to never come back because it's going to say you hurt them. So irritability, in my opinion, is the biggest. That's the number one question in my mind. Treatment approach. Okay. In my opinion, stretching this person is a waste of time. That's my opinion. They'd already tried to stretch, didn't change anything, and it caused them some pain. In my opinion, this is a tendinopathy, a hamstring tendinopathy with a little bit of nerve irritation. I would go into isometrics on day 1. I think this is the kind of patient who is a home run for dry needling. Dry needling, in my opinion, from a clinical decision-making standpoint, is pretty sketchy. We do not have great literature that guides us into how to use this and when to use this. The effect sizes are incredibly small, if not non-existent. That doesn't mean in the future there isn't going to be some, and I use it. But one of the things that I've had the biggest success with in dry needling is an acute overuse injury. This woman, in my opinion, would respond great to dry needling. I would progress her into isometrics on day 1. Could do some slump sit or some neural glides in supine, like a 90-90 knee flexion extension, or I could do a straight leg raise, whatever would be that she could go home and work on. Hamstring sets to calm it down. Maybe some manual therapy to the lumbar spine. Certainly manipulate. Maybe some mobs. Check out how the hip moves. Maybe some mobs there. I've also done some mobilizations of a posterior glide with the hip with some active knee flexion extension from a neural standpoint to calm that down. We can maybe do that. But she's going home with hamstring isometric. She's going home with a neural glide, and maybe she's going home with some hip abduction strength. I also like to do a supine marching exercise that I learned from Zach Long, the barbell physio. Go check out his website. He's a CrossFit guy, a physical therapist who specializes in training CrossFit athletes. His stuff is really good. Again, barbell physio, Zach Long. I think he does great stuff. He's got some great progression videos for those higher level athletes. But the supine marching with TheraBand, I think, works really well with people who have hip flexor tendinopathy and some hip flexor weakness. Don't discount that. But I would probably add the hip flexor stuff on the second visit, and then just go harder into butt strengthening on the second visit, and then start to do some like straight leg bridging with leg up on like a chair progression, if you will. All right. That's my thought on that. Now, that's not to say there couldn't be other ways to do it. That's how I would have done it. But I don't think we should be stretching this patient a lot. And I don't think we should be afraid to engage that hamstring muscle, because I do think it's a tendinopathy. So, great. So that's kind of my 2 cents on the course. So, again, thanks for a great course. I've enjoyed meeting all of you. In the beginning of this course, just getting this course off the ground was a bit of a struggle, just because of the weather, and some of the weather-related issues for almost half of the class, maybe even a little bit more than half of the class. I appreciate all of you hanging in there, staying with us. Engaging each other, challenging each other, thinking differently, challenging your thought processes. Please, please, please don't stop looking at the literature. Continue to challenge, why do I think the way I think? Continue to challenge why your coworkers think the way they think. Is it right? Is it not? Is it supported by literature? Could the literature be stronger in this area? What are you looking for in future literature? Be consumers of the literature. Be consumers of the science. Think critically. Don't just follow the dogma. Don't just follow what other people are doing. Be individual PTs that have a sound clinical reasoning and formulate good thought process based on what the literature says. If you ever have any questions, feel free to shoot me an email at chriskramerpt@gmail.com. I still interact with many of my students from past. If you're ever looking for a fellowship mentor, I do that. I had a fellow with me this week from Nebraska. People come up and hang out with me. Would be certainly always willing to do that. Just want to encourage continued professional growth, because it's a great profession and the future is great, and what we do matters. We are definitely value added. On that note, good luck in the future. Stay in touch and have a great weekend. Bye-bye.